I just want to say thanks again and welcome Dr. Stephen Huege. He is a board-certified geriatric psychiatrist who specializes in treating mental health and neurodegenerative diseases in older adults, including both chronic and new onset mental illness. His areas of clinical expertise include Alzheimer's disease, Lewy body dementia, frontotemporal dementia, and mood and psychotic disorders in older adults. Dr. Huege, I'm sure, wears a gazillion hats at UCSD, as many of our faculty and clinicians do. But he is the director for the Geriatric Psychiatry Fellowship Program and has done a lot of research in the area of medical education, specifically in curriculum design and teaching of geriatric health. So that's just a brief overview. I'm really excited about this presentation today. I think it has a lot of implications for our clinical research team and a lot of the people who attend this. So thank you so much for presenting today on the management of behavioral disturbances and neurocognitive disorders.
Oh, thank you so much for having me. It's a pleasure to be here this afternoon with all of you. Yeah, so as mentioned, I'm going to talk today a little bit about sort of the management of behavioral disturbances and neurocognitive disorders. This is a topic that I think any of you who work with patients with any sort of neurodegenerative, neurocognitive disorder will most likely encounter at some point and can be quite vexing. So happy to share some thoughts, experiences in working with these patients and their families. And oftentimes, as we'll see, it's the family is as much your patient as the actual patient. So just to kind of go through an outline, we'll talk about a brief introduction. We'll talk about some terminology and definitions. We'll talk about how behavioral symptoms can manifest. Also looking at how do we differentiate from other conditions, what are some of the consequences, and then focusing on treatment and management. So, if we think about what is dementia, right? I think we all have certain definitions, certain criteria, but I think sometimes it's helpful to kind of go back to basics when addressing this question, just because it can help guide some of the advice and counsel that we give patients. So fundamentally, we can think of dementia as a condition or a syndrome of acquired cognitive impairment. So this has to represent a decline from a previous level of functioning. And this is different than patients who may have developmental disabilities that they've had for a long time or learning differences. And that's not to say that those patients can't develop dementia down the line. In fact, if you look at patients with Down syndrome, for example, invariably they will develop Alzheimer's disease at a relatively young age. But I think it's helpful to keep in mind that essentially when we think of dementia, we're thinking about a disorder of acquired cognitive impairment. That is a change from one level of functioning to a lower level of functioning. And sometimes it's that change that causes the most distress. And also, as we'll talk about, it's important to look at lifestyle, right? Because certainly there are patients who lead very cognitively challenging lifestyles who are going to notice more subtle cognitive impairment than patients maybe whose lifestyle is much more simplified. And I sort of talk about, when I was in training, we sort of talked about the 4As, aphasia, amnesia, apraxia, and agnosia as kind of the hallmarks of dementia. And back when, I think we really used to focus on dementia as a disorder of cognition. And while that was helpful, I think it failed to include more of the neurobehavioral, neuropsychiatric symptomatology that, at least as a geriatric psychiatrist, I often see. And so initially I was kind of skeptical about the whole, when it first came out, the term major neurocognitive disorder. And I'm probably dating myself here, that I can remember when it came out. But initially I was sort of thought this is just a way of kind of trying to euphemize something that is pretty devastating. But I actually have it's kind of warmed up more, kind of grown into it and actually find it quite helpful now, because I think that it's really important to expand our concept of dementia and really think of it not just as a disorder of acquired cognitive impairment, but really as sort of a neurocognitive, neuropsychiatric, and neurobehavioral condition, because really all of these facets are involved in these conditions in some way and in some fashion, and to greater degrees throughout the time course of the illness. So I often find the NIA criteria for dementia very helpful, and I go to these sort of core features in that the cognitive or behavioral impairment, I think that that's really key, that they include behavioral impairment, involves a minimum of 2 of the following domains. So certainly impaired ability to acquire and remember new information. So memory, again, sort of going back to sort of classic notions of dementia. But it also includes impaired reasoning and handling of complex tasks and poor judgment, impaired visual spatial abilities, impaired language, and importantly for the work that many of us do, changes in personality, behavior, and comportment. And as we'll see, sometimes it's really these sort of more behavioral symptoms that are really where things first start to manifest. There's sort of, when we think about behavioral changes and disturbances in dementia, there's a multitude of terms that get used. Again, maybe dating myself here, but sundowning is a term that you'll hear quite a bit, and the sort of working definition of sundowning is the emergence or worsening of neuropsychiatric symptoms in the late afternoon or early evening. And this term often gets used in settings where you start to see a lot of changes in behavior kind of around the end of the day, sometimes associated with changes in ambient, kind of environmental lighting. It's a term that I kind of avoid, because it has pretty strong temporal connotations, and it's somewhat non-specific. I think sometimes too, I've had patients where they kind of, I would say, normalize it, but it is a term that still is out there. It does get used quite a bit. Again, I tend to shy away from it because of its sort of very specific temporal associations with late afternoon, early evening. Another term that gets used a lot is agitation. And years ago, I sort of came up with this kind of working definition of agitation, in that it is a set of behaviors that cause a disruption in the environment and/or patient care that may potentially lead to physical or emotional injury of staff, patients, or peers. And I kind of like this because it kind of focuses on a couple of different things. One is the element of disruption, right? Why, somebody can be talking and repeating themselves and just sitting in a corner, and while it may be a nuisance, it may be unsettling, it's really when you start getting that disruptive element that really starts to come into play, right? So it's when the person who is maybe repeating themselves or asking the same question over and over again starts coming, if you're in a nursing home setting, starts coming over to staff and is repeatedly asking them the same question to the point where they can't attend to other care needs, or a family member who maybe is trying to focus on a particular task and has to stop what they're doing to continuously provide reassurance to their family member. And then the other part that I think is really critical is the potentially leading to physical or emotional injury. And I think, the physical injury stuff, instances where there's physical injury grab our attention. Those are the ones that really cause a lot of panic and upset amongst staff and others. But I think just as important and perhaps more insidious is the emotional injury that can occur. And this can take on a variety of forms, right? This can include critical or demeaning comments, sometimes comments that are of a particularly racist or sexually demeaning nature. And I've been in working in a variety of settings, I've had people say, you know what, I can take the hitting and slapping and kicking and punching, but when they use fill in the blank term, that really gets to me. Or, when they start, making really sexually lewd or inappropriate comments, that's where it really, I feel like I can't take it anymore. And so I think that component of both the physical and the emotional injuries is really critical. And again, it can involve all players, right? I think it's helpful to think of it as almost like a patient care ecosystem that, the actions of all involved have consequences and can affect the well-being. And then sort of this other term that gets used a lot, and I'll use predominantly throughout the rest of the talk, is behavioral and psychological symptoms of dementia. This is defined as signs and symptoms of disturbed perception, thought content, mood, or behavior. And this sort of has a more clinical kind of focus to it, and is one that gets used quite a bit in the literature. But these are just some just examples of terminology that you'll see. So we think of agitation, again, kind of going back to this concept of agitation, we can think of it as physical and verbal. So physical things include hitting, biting, attacking others, but it also can include removing of indwelling medical devices, things like intrusion into the personal space of others, pacing, causing bodily injury to self or others, things like disrobing in public or inappropriate places, aggressive or non-consensual sexual activity, destruction of property. And verbal, again, yelling, screaming, repeated questioning of staff or making demands for attention that become intrusive or excessive or impede the care of others or activities of the caregiver. And of course, using offensive or inappropriate language. So these are just ways in which agitation can appear and manifest. This is by all means not an exhaustive or fully inclusive list, but includes some of the most common scenarios, things that you can say. So shifting more to BPSD, if we think about sort of more specifically psychiatrics and thinking more clinically, this can include an array of behaviors and symptoms. So it can include apathy, which is different than what you might see in depression. Usually the patient with depression who has low mood is more bothered, they're sort of more of an acute distress, whereas the person who's displaying apathy is more kind of just disinterested. There's almost a lack of care, really. And again, apathy can often be very emotionally distressing for family members. Especially when you sort of get to the element of combining with low motivation or difficulty initiating tasks. The way I often kind of think, I kind of explain it to family members is that the frontal lobe in your brain kind of acts as like a mental speed bump, so that it kind of slows you down so you don't just say or think or do whatever's on your mind or whatever comes to mind. But unfortunately in dementia, that speed bump can either become a flat surface in which patients just say, think, or do whatever comes to mind without any kind of filter, or conversely, it almost becomes like a brick wall that nothing can pass through. And sometimes, we'll encounter situations where family members are like, he just won't do anything, that he won't do anything by himself. And that really what we're looking at is sort of the process of translating a thought or a will into action. Anxiety can often be a significant stressor, particularly related to issues of being alone. This is where kind of you can see sort of co-occurrence with rapid forgetting, patients who kind of need that constant reassurance. Psychosis can be particularly disturbing and unsettling. Usually kind of takes on the form of, at least with Alzheimer's disease, more sort of paranoid thinking, suspiciousness. Although in certain conditions like Lewy body dementia, you can see visual hallucinations, for example. That can sometimes be quite unsettling. Sleep disturbances are a big one and often a significant source of caregiver frustration and burnout. If people can't get a good night's sleep or can't sleep through the night, that becomes very distressing, particularly if the person is getting up and doing things in the middle of the night. Trying to leave the house, engaging behavior that might be dangerous. And then, of course, sort of the general sort of catch-all agitation, aggression, or combative behavior. And this can take on a variety of forms, right? It can include care refusal, so people who need support and assistance with basic ADLs, just not cooperating. It can include wandering, sometimes trying to leave one's home. Again, so we talked about sexually inappropriate behaviors or even physical violence. As I'm sure this is no surprise, these kind of symptoms can occur in up to 90% of dementia patients. They cause significant distress to caregivers. Patients who have behavioral and psychological symptoms of dementia, you see higher economic burdens, greater levels of care and supervision are needed for these patients. Caregivers often require more time off from work. You see a high degree of emotional distress. You can really see things like burnout, even depression, suicidality in family members, just overall diminished quality of life. Patients with these kinds of behavioral symptoms have greater functional impairment. And invariably, it leads to greater rates of hospitalization and institutionalization. Families, in my experience, families will put up with quite a bit of cognitive and even functional impairment. But when you start throwing psychiatric symptoms into the mix, that's where people, I think, their patience and their ability to compensate really starts to diminish rather quickly. I've had patients where, I sort of think of them as kind of like pleasantly confused, where they are very cognitively impaired, but they're very easygoing, they're cooperative, they're not exhibiting any of these kinds of things. And those kinds of patients are often able to stay in their own home or live with a family member quite into, with significantly advanced neurocognitive disease, and sometimes even for their entire lives until their natural end of their life. Whereas patients who maybe have less cognitive impairment, but really significant behavioral symptoms, those are the folks that get placed in memory care, assisted living, or even inpatient units much more readily and quickly and early on in their illness. And you often see this with like frontotemporal dementia, where oftentimes the patients are often quite younger. And that in and of itself can be a source of distress, where you have patients who are sometimes a generation apart from the rest of their peers in settings like assisted livings and memory care units. So if we think about assessment of behavioral and psychiatric and psychological symptoms of dementia, there's 3 models that I found. So these were DICE model, the Wisconsin STAR, and TIME. So I personally like the DICE one the most. Involves describe, investigate, create, and evaluate. So first and foremost, you describe the problematic behavior, because sometimes that's where people sort of get lost, right? That there's so much attention placed on a specific or a singular activity that sometimes other more subtle details get lost. Also thinking about investigating, right? What are possible causes, right? Usually if you dig down deeply enough, you can find some sort of precipitating stressor or cause. And then sort of creating a treatment plan, right? What can we do to try to address some of these behaviors in a very targeted way? And then, of course, evaluating it, looking back and saying, was this efficacious? Did this work? Did this cause more problems? I like this because it's applicable in a broad array of settings. You can use it in the home setting, you can use it in a nursing home, assisted living, an inpatient unit, medical unit. And it also takes into account pharmacological and non-pharmacological intervention. So I kind of like this model. This is probably sort of what I do when I'm in practice. Another model that I think is also kind of interesting is the Wisconsin STAR model, and this focuses on 5 different domains and the interaction. So you look at, what are possible underlying medical issues? And we'll talk more about kind of thinking about delirium. What are possible medication contributions and factors? Are there social, environmental factors that might be playing a role, right? Is this an environment that's new or unfamiliar? Are there significant rapid turnover in caregivers? What's the underlying personality of the person like, of the patient, right? Is this somebody who historically has been pretty independent and strong-willed? Or is this somebody who maybe historically their nature is a little more calm and easygoing? And of course, what are the different behaviors that are being exhibited and in what settings? And looking for interactions amongst these, right? Is it maybe, certain, with X caregiver, they're more comfortable with more personal kind of toileting type care than with somebody else, for example? Or is there a time of day, or maybe targeted medication might help with a certain behavior? HIME is another one. Looks at its targeted interdisciplinary model for the evaluation and treatment of neuropsychiatric symptoms. This was a model that was developed in Norway for nursing homes, but it involves a 3-phase approach. So one is registration and assessment, so kind of identifying the symptoms, kind of doing an assessment, sort of a guided reflection. This can involve a case conference, so kind of looking at it as a group. Again, looking at some of the other factors that we talked about, some of the other models, and then putting together an action plan, and then coming back and evaluating the efficacy of that. So again, in my experience, sometimes it's the psychiatric and behavioral symptoms that are the first indication of a neurodegenerative disorder. In geriatric psychiatry, patients come broadly in 2 different flavors. There are patients who have history of psychiatric illness and age with those conditions. And then usually what happens is their psychiatrist retires, and then they need a new psychiatrist. And by that time, they're of a geriatric age. So they wind up getting placed with a geriatric psychiatrist. Versus the other type of patients are patients who have never had any kind of psychiatric symptomatology before, and then start to develop symptoms like depression, anxiety, or even more severe problems like psychosis. In my opinion, a new onset of psychiatric symptoms, or a new onset of particularly severe symptoms, to me, I'm looking for a neurodegenerative disorder, particularly things like psychosis. Somebody who's never had any kind of psychiatric history before, somebody who presents with psychosis as an older adult, it's almost kind of proved to me that this isn't dementia. Because, and the reason some of these kinds of psychiatric symptoms are what bring the patient to attention is that, the cognitive symptoms often develop very insidiously and sort of slowly. I kind of like the analogy I like to use is it's like watching your grass grow, right? If you get your lawn cut and then the next day, you're not going to notice much of a change. But if you go away for a few weeks and then come back and it hasn't been mowed, you're going to notice it more. And the cognitive symptoms are kind of like that. Again, and because these symptoms can evolve very slowly, oftentimes, sometimes unconsciously, families or significant others will adjust almost imperceptibly, almost without being aware of it. And oftentimes what we'll see is that, particularly a situation where there's maybe a married couple or two people living in the same household, often what happens is the non-cognitively impaired person will start to carry more water for the cognitively impaired person. And then what happens is the person who was not cognitively impaired has some sort of medical illness or some other incident, gets taken out of the picture temporarily or permanently, and then the rest of the and then that's where you really start to see the cracks in terms of their functional abilities and where things really come to mind. And it was because, well, this has been going on for some time, but the other person was compensating. Whereas when you see things like severe depression, anxiety, delusional thinking, that's much harder to ignore and to compensate for. And that those are the things that really grab people's attention. So sometimes it's convincing them that, no, this is not primarily a typical classic psychiatric condition. This is really a neurodegenerative condition. And I'm sort of having that discussion and trying to demonstrate that this is a neurocognitive disorder, as opposed to purely something like a major depression with psychosis. Again, we talked a little bit about this, but lifestyle is really critical and can play a big role into why a patient might be having behavioral and psychiatric symptoms, right? And it can give us a lot of crucial insights. One of my favorite questions when I'm interviewing patients is, what is your routine? Kind of take me through a typical day. How do you spend your time? Because this often can be quite illuminating, right? It's one thing if a patient's like, oh yeah, I do this, and I go out here, and on Thursdays I have this activity, I go to the gym, versus somebody who, they don't leave the house, they're pretty much at home, maybe they're just watching television. What's their sleep patterns like? How are they sleeping? To me, sleep is like a barometer of mood and well-being. If sleep is off, you'll often see cascading effects in other domains. Are you seeing day-night reversal, right? Are they sleeping during the day and up at night? And sometimes that happens because of medications that we prescribe. This often can be a cause of distress, right? I've had patients where, their significant other is like, they sleep all day and I can't go out, but then they're up all night. What's their appetite like? How are they eating? Are they having difficulty with eating? Are they having problems with choking, dysphagia? Are they at risk for aspiration? Looking at sort of what's the level and type of activity, right? How much time are they spending in their home versus getting out of the home? I tell patients, I don't care how nice your house is, if you never leave it, that's often a recipe for a problem. That everybody's going to go a little stir crazy after a while. So what is their level and type of activity? Who are they doing that activity with? And then also, what are the caregiver supports and stressors, right? What's going on in that person's life? What are they juggling? What are they having to give up or stop? It's challenging. I sometimes encounter a lot of caregivers who they really put their lives on hold, having to care for a family member. Or sometimes you have somebody who is maybe having a lot of difficulty or challenges themselves, and that's why they've sort of been chosen, selected, fallen into the role of caregiver for their family member. It's because maybe they themselves have never fully launched, or they have their own medical or other mental health type of difficulty that they're dealing with. So that's another important consideration, right? Again, what's the ecosystem in which this patient is existing in? Also important and easy to overlook are basic physical needs, right? If you think about sort of like the pyramid of like needs, Maslow's hierarchy of needs, sometimes just addressing really basic things, right? Like, is this patient getting enough to eat? Are they eating, are they thirsty? Are they getting enough hydration? are there unmet pain needs? And, the treatment of pain in older adults can be really challenging. I mean, there's a lot of contraindications to different medicines. Culturally, medicine has become much more reticent about aggressively treating pain, particularly with opiates. And I'm not judging that or saying that's inappropriate, but just it's a different landscape than it was maybe a decade or so ago. A lot of, I push a lot of like topical analgesics on patients, things like topical lidocaine, topical NSAIDs, particularly like the topical lidocaine. I tell patients and their families, think of it like sunscreen. Like you can really lather it on, kind of go to town with it. Are there other elements of discomfort? Maybe clothing that's ill-fitting, uncomfortable beds, chairs. Are they sleeping in a lazy boy? That's not that great. Unless you have like the Cadillac of like armchairs or something like that, but still, what's their level of energy, right? I often tell family members, think of yourself on like your worst day, whether, like jet lagged or up all night studying, and then superimpose upon that cognitive functional impairment, sometimes sensory impairment. That's another thing that we often ignore, right? Can the patient see and hear adequately? I often encourage patients to get hearing aids. That's a big, untreated hearing loss is a big risk factor for dementia. It can contribute to a lot of agitation. I know for a lot of folks, they worry about losing hearing aids and that they're very expensive. Sometimes even something like a pocket talker. Now they have sort of earbud-like devices that are relatively inexpensive, but correcting or addressing sensory impairment, vision, hearing loss, because often that can be quite disorienting for people. Again, emotional factors, right? Is this somebody who's experiencing a lot of anxiety? Is there a lot of rapid forgetting? Are they unable to retain basic information that maybe you gave them even just a couple minutes ago? Oftentimes I tend to think of, patients as sort of, is this a bus or a plane conversation, right? Are they able to, you think about typical city bus rides, maybe 20 minutes or so, is a patient able to kind of hold it together for about 20 minutes and sustain a conversation with still being able to keep the train of thought? Or are they more intact and can sustain conversation for something more like a plane ride, 2-3 hours without forgetting? Oftentimes you just see a general decreased level of frustration tolerance, right? Sort of we think about, we all sort of have mental strategies to kind of talk ourselves down when we're feeling stressed. Well, imagine that you're losing that ability to kind of talk yourself down, kind of calming thoughts, soothing thoughts, rationalizing. And oftentimes this is something that some families really struggle with, that sort of this kind of gets into like the psychological mindedness and taking on the perspective of the other person. Again, language or impairment, aphasia can make communication difficult. Loneliness, right? That sometimes death or loss of care of a family member, caregivers, a spouse or a partner, being in an unfamiliar environment, untreated depression, and sometimes depression in these settings is harder to treat. Again, if you think about the treatments that we have for depression, they were developed and tested and approved in non-demented patients. And so you're really kind of juxtaposing treatments that were developed in one setting for a very different patient population. Is there, psychotic issue, sometimes having paranoia, are they having suspiciousness? Sometimes this can be really hard to help patients with. And sometimes it can be really distressing to caregivers. Again, I had a couple of patients where, there was delusions of infidelity, and it caused a lot of distress on both ends, both the patient who was having the delusion and the spouse who was sort of the target of that delusion. a spouse once who was like, there's no way I can convince my spouse otherwise. And I was fairly sure that they weren't. Again, I guess you can never be 100% certain, but from what it seemed that this patient was not having an affair. Of course, it's really important to rule out delirium. And we think of delirium as a disturbance in fluctuating level of consciousness with difficulty or inability to sustain attention. You can see perceptual disturbances, disorientation. The reason it's so important to be mindful of delirium is that it really can be indicative of a life-threatening medical issue and that needs to be addressed in a very timely fashion. Unlike dementia, delirium tends to develop and evolve very quickly. Often I will tell patients and tell their patient families, if you see a rather precipitous decline in their cognition or change or rapid onset of anxiety or paranoia, get them evaluated medically very, very quickly, because that more than likely you're dealing with some kind of underlying medical issue or delirium. As opposed to dementia, which again has a slow, steady, you're not going to see much change day to day. The other thing too to be mindful with delirium is you can have periods of hyper and hypoactivity. Sometimes it's the hypoactively delirious patients that get into real trouble because they just sort of lay there and do nothing. Those are the patients that you can often miss and can have really significant medical outcomes. Disturbed sleep patterns, again, a lot of day-night reversal. And this is something you want to be really mindful of and always have a low threshold for investigating for. Other non-psychiatric, non-neurodegenerative things to be mindful are medications, right? So things that we give to patients. Many of our patients have complex medication regimens. There's a lot of polypharmacy out there that we need to be mindful of. Coming back to untreated pain, constipation, right? Is this patient having regular bowel movements? Are they drinking enough fluid? Are they getting enough activity? My predecessor, Dan Sewell, loves to talk about the patient who gets admitted to the senior behavioral health unit, agitated and confused, and then you get them on a proper bowel regimen, they have appropriate bowel movements, and they clear up and are fine. Underlying infections, other toxic metabolic conditions. So again, just be mindful. We want to be careful of dismissing or just thinking that all of the patient's behavior is attributable to their underlying dementia. It's really critical to be mindful that there can be other non-neurodegenerative issues at play. Again, caregiver distress is a big one. Again, sometimes it's the caregiver that is more your patient than the patient. Certainly sometimes it can feel like the patient's kind of a sideshow. And sometimes this can be a key driver of visits to physicians. The early presence of neuropsychiatric symptoms in the course of dementia is a significant predictor of overall burden. Again, issues related to interrupted sleep. Sometimes you can see a lack of support from other family members or outright denial, and sort of family members kind of being pitted against one another. This often can cause a lot of distress. Sometimes you see this in blended families. Perhaps there's a certain level of estrangement, or a spouse who is not the parent of the patient's children. Sometimes too, there's a misunderstanding or a misattribution of intent and lack of comprehension of the underlying cognitive impairment. Sometimes you'll hear things like, they're just doing this on purpose. They're doing it to upset me. If only they would just stop. They won't listen to reason. Well, yeah, they're not going to understand reason. And so really educating them about this is a different family member in some way than perhaps you're used to, and that their ability to process and understand information, retain that information is impaired. Their brain is just not working properly. Again, as we talked about, this can often be disruptive in the life of the caregiver. Again, it can involve taking time away from work, from caring for other family members, particularly young children, sometimes putting things like school and other relationships on hold. And another issue that often comes up is guilt about placement, or having to enlist other caregivers. I see a lot of family members where they'll say to me, oh, I promised I would never put them in a nursing home, or what does it mean that I can't take care of them by myself? And invariably I have to tell them that this caring for somebody with a neurocognitive disorder is not a one-person job. That it invariably becomes more than one person can handle by themselves. But often there can be a lot of guilt around this and needing for care, or feeling, caregivers feeling like I failed because I need to get help, or I failed because I have to put them in a nursing home or a memory care unit. And often I will encourage caregivers to go into counseling and therapy themselves. Find somebody who has sophisticated awareness of what it's like to be a caregiver. Support groups can be helpful. Some folks really gravitate towards that kind of intervention. But it really is sort of the putting on your own oxygen mask first kind of thing. And so I figured I would do non-pharmacology first because it's the pharmacology that gets a lot of attention. And some of these seem pretty basic, but oftentimes they can be harder than to put into practice. But certainly trying to correct day-night reversal. This involves kind of being careful with medications, timing of medications. Having a structured routine really helps some folks, a routine that's predictable. Using a calendar and writing out schedules that you can point to and reference. Spending time outside of the home if it's feasible, even if it's just like sitting in the backyard for a couple of hours. Trying to minimize daytime napping, particularly if it's impeding their ability to sleep at night. That's a question I often get asked, is it okay if I nap during the day or if they nap during the day? Well, as long as they're still sleeping through the night, I usually don't have a problem with it. But if they're napping all day and then not sleeping at night, then that's a problem. Finding activities that are appropriately stimulating. And this is often one where things can get a little sticky with caregivers. You'll have the caregiver who, very well-intentioned, is trying to push their family member into activities that are too cognitively demanding and cognitively intensive, or just above the ability of where that person happens to be at, and often causes great distress. And so it's finding activities that are appropriately stimulating and engaging. I've had a lot of luck with some patients with sensory processing toys and objects. So if you look at some of particularly in the autistic spectrum literature, so things like weighted vests, rice boxes, fidget toys, vibrating toys and objects, weighted blankets. Sometimes some of these kinds of sensory interventions can be very helpful. Sometimes occupational therapy is very knowledgeable about some of these things. Looking at respite, whether that's maybe having a different family member take over for a few days, looking at maybe a respite stay in an assisted living or a memory program, the importance of day programs, senior centers, adult daycare. Those can often be lifesavers for families. It gives a sense of routine and structure. And sometimes it's hard. There can be a lot of resistance. I usually try, if the patient has enough cognitive ability where you can kind of reason and engage in a fairly meaningful discussion with them, I'll often tell them, try it for a month and see, just try it for a month, right? No long-term, like on television, like no long-term commitment, you're not signing your life away, but sometimes getting buy-in can be difficult. So talking about pharmacology as in the last 15 minutes or so, So the antipsychotics, again, the whole black box warning, which really disconcerts a lot of people. And that's understandable. This kind of dates back from the early 2000s, where they found number of studies. One early one looked at showed an increased risk of cerebrovascular adverse events, including stroke, in patients on risperidol compared to placebo. There was a meta-analysis of 17 placebo-controlled trials using atypicals and dementia, showed an increased risk of mortality with atypicals versus placebo, relative risk of 1.6 to 1.7. This black box warning is applied as a class to all atypicals. So one is not necessarily safer or better than the other, with a caveat. Again, it's again, some patients and their families are at the point where, like, I'll do anything, I can't deal with it. And other patients and families are much more sensitive, attuned to the black box warning and issues related around that. It's a trade-off. Like anything in medicine, like any treatment, you have to evaluate risks and benefits. And I think it is important, though, to educate folks that untreated agitation is dangerous as well. It carries its own risks. People can get hurt, patients can get hurt. So doing nothing is not a benign intervention. And that, yes, there may be an increased risk of cardiovascular events with these medications. But given that you are dealing with a patient whose life expectancy is somewhat more limited, and that this is a progressive condition, is that potential trade-off in morbidity, mortality worth it if you see an improvement in quality of life and decreased caregiver distress? And every patient and family has to make that calculus for themselves. I can tell you, by the time most people come and they're seeing somebody like me, usually they're like, whatever we need to do. But it is important to just be mindful of this, talk with patients about, they'll usually ask. If they don't, I bring it up preemptively. Sort of looking at atypicals, meta-analysis, they are somewhat helpful. That there is modest efficacy. Again, are they great? No, but again, these are medicines that were developed for an entirely different purpose, right? One study showed that atypicals have a small effect on agitated patients. Sort of the caveat that I mentioned was brexpiprazole, which is the first agent to receive FDA approval for the treatment of agitation associated with dementia due to Alzheimer's disease. It still, though, as an atypical antipsychotic, carries the black box warning. But if you can get it approved by insurance, at least you're going with something that's FDA approved, has an indication. Before that, I used to kind of joke that, like child psychiatry, a lot of what we do is off-label. Again, what they found was that patients who received 2 or 3 milligrams of brexpiprazole had statistically significant and clinically meaningful improvements on CMAI scores compared to placebo. Antidepressants. So the CITAD study looking at citalopram actually did show a positive effect on agitation. The downside was that there was some QT prolongation at doses greater than 30 milligrams a day. So you could consider escitalopram. There was a recent study looking at mirtazapine, which showed no difference with placebo on mean CMAI scores. And it was actually associated with potentially higher mortality with mirtazapine. So be careful about mirtazapine. Trazodone often gets used a lot. It's fairly limited evidence. High risk of falls, orthostatic hypotension. Often see a lot of lingering morning sedation with trazodone. People often ask about the cognitive enhancers. I think they play a role for some patients. They can be somewhat helpful. In general, I think they're worth trying, especially early on. Although usually if somebody is having really severe agitation to the point that they need to go in the hospital, usually you're beyond the point at which a cholinesterase inhibitor or memantine is going to really be that helpful. And usually most patients who get admitted to senior behavioral health get these medications discontinued. Usually what my advice for patients and families is that, how long to stay on them when that becomes a question. Usually I'll say, let's set a point at which we can sort of feel that they've outlasted the benefit. And usually that's either if they need to go into a memory care unit or they are no longer able to perform their BADLs on their own, but sort of having a point in sort of a threshold that you kind of establish with the patient and their family that, okay, once we get to this point, I think we can sort of safely say that any benefit is we've probably gone beyond any duration of benefit of these agents. Other agents, valproate gets used quite a bit. The problem with valproate is it's not a benign medication. You have to monitor LFTs, risk of CBC abnormalities. I'm not a huge fan of valproate. There's an interesting Cochrane review looking at cannabinoids that gets a lot of attention. They looked at 3 particular agents for which there was limited data for efficacy. Again, some patients will try this on their own or their family members. Sort of what I tell people is you can try it. It's kind of a wild west out there in terms of, try to see if you can find a dispensary that's pretty reliable, that you can have as much confidence as you can that what you're getting is really what's labeled is what you're really getting. There can be a wide variability in terms of CBD versus THC, THC being the more psychoactive component. I generally don't like benzos. I avoid them in older adults, period. The dextromethorphan quinidine combination agent, does have some evidence to suggest that it's helpful. I kind of view it as kind of a niche medicine. There's some people who do benefit from it. It's not one that I use a lot. But sort of the general take home is that behavioral and psychological symptoms of dementia contribute to significant patient and caregiver distress and comorbidity. The treatments that we have are relatively limited with some noteworthy risk. That doesn't mean that we shouldn't use our pharmacological treatments, but also there's an important role for non-pharmacological treatments. It's crucial that we examine environmental factors, that we focus on quality of life, and that medications, including antipsychotics, can play a useful role, but the use of them does require pretty careful monitoring. And references, and with that, thank you.